delayed by 20 minutes almost. So please play the slide. Next. I'll like to introduce the team who will be doing the hands-on workshop with you. I'm glad to introduce Dr. Sanjay Rao, who is senior consultant and head of Department of Pediatric Surgery in Narayana Vidyalaya. With he's well known and his special interest is in airway surgery and transplantation. Next tweet, please. Yeah, next please. Yeah, I'll glad to introduce Professor Vikram Kishore Behera. He is a professor of anesthesiology and critical care from AIIMS Bhubaneswar. He is a very well-known anesthetist and has special interest in pediatric anesthesia also. He is a recipient of Vrindavan Chandra Memorial Award for Best Scholars in Physiology in his MBBS days and awards from NC Kaushik Memorial Award for Best Free Paper in Anesthesia and published, well published more than 40 international and national research activities. Next, please. Yes, Dr. Krishna Mohan Gulla. He is additional professor in Department of Pediatric Surgery in AIIMS Bhubaneswar. He has he's done his MD Pediatrics and DM Pediatric Pulmonology from AIIMS New Delhi and trained in ECMO from Taipei, Taiwan, and fellowship in ECMO Sciences. Has special interest in critically for nutrition in critically ill children and extracorporeal life support. So he does a lot of pediatric flexible bronchoscopy in our center and interventions including foreign body removals. So we are getting less foreign body removal to do these days because of his expertise. So I thank you, Dr. Krishna, Dr. Vikram, and Dr. Sanjay to be here. Let's start the session. So it will we'll start with a introduction by Dr. Vikram. Please come.
Thank you, Dr. Santosh. Good day to all of you. Seasoned pediatric surgeons, budding pediatric surgeons, MCS residents, welcome to Bhubaneswar. So in the next 10 to 15 minutes, I'll be taking you through pediatric bronchoscopy. The context will be foreign body aspiration or foreign body inhalation. I'll be talking on the indications, preoperative preparation and evaluation, monitoring, and pharmacological techniques for the removal of the foreign body using bronchoscope, and postoperative care. My slides are not visible. Yeah. So, as all of you are aware that foreign body aspiration into the airway is a serious and sometimes life-threatening condition, and it can result in mortality. One report from India tells that around 7% of the child die within the age group of 0 to 3 years because of foreign body inspiration. But the Western data is different. The death due to foreign body aspiration is almost negligible and it reaches almost zero. This is because of unavailability of trained personnel and facility and bronchoscope at various parts of our country. And why this age group is vulnerable? As you know that they have poor chewing ability and their airway protection reflexes are not that great. And this child, they tend to explore objects with their mouth and they eat while crying and playing. This makes them vulnerable for foreign body inhalation into the airway. And the common presentation of foreign body inhalation is sudden onset of difficulty in breathing, continuous coughing, wheezing, choking, and episodes of cyanosis. And almost always there is a definitive history of foreign body aspiration. If it is missed, if it is not witnessed, then the child usually present with chronic cough, fever on and off, and breathing difficulty. And usually there is no history of witnessed foreign body aspiration. And these children, they go to pediatricians and they are treated in the line of asthma, tuberculosis, and they receive repeated doses of antibiotics. So what are the indications for foreign body? Bronchoscopy for foreign body aspiration. If it is a witness foreign body, or you have a very strong suspicion of foreign body aspiration, like history of choking episodes followed by sudden coughing, wheezing, or respiratory distress, then there is a definitive indication for doing a bronchoscopy. What are the clinical signs that are very much suggestive of foreign body aspiration? One is sudden onset respiratory distress, choking, cyanotic episodes, unexplained stridor if it is an acute foreign body aspiration, and then wheezing, decreased air entry into the one side of the lungs, persistent cough that do not respond to usual therapy, recurrent pneumonia in the same lobe of segment. Coming to the another indication for bronchoscopy, if there is direct visualization of a foreign body by radiology, be it an X-ray or CT scan, then also you will do a bronchoscopy. Or if there are indirect signs of foreign body aspirations like the hyperinflated lung fields, atelectasis, or lobar collapse, or obstructive emphysema, then also it is an indication for doing a bronchoscopy. Then what are the indications for diagnostic bronchoscopy? If the radiology is normal, you do not find any signs of foreign body aspiration, but you have a very high clinical suspicion, then also negative radiology with high clinical suspicion, you will do a diagnostic bronchoscopy. Then once you decide that you will go for diagnostic bronchoscopy or therapeutic bronchoscopy, what are the pre-procedure evaluations? So take a thorough clinical history, take the event details when apparently the child was normal, when did this choking episode started, was it abrupt in onset, or is the child having this respiratory symptoms chronically, what was the time and duration since aspiration, is the child suffering from any significant medical diseases, and time to last meal. If the child is not in severe respiratory distress, then you have enough time to do some labs and radiology. If the child in severe respiratory distress, the child can be directly taken into the bronchoscopy suite for retrieval of the foreign body. So do not forget A, B, C. A is for airway, B is for breathing, C is for circulation. This child who are in respiratory distress will have stridor. There will be voice changes, intercostal retractions. The respiratory rate will be very high. They will be desaturating, and the work of breathing will be very high. If there is hypoxia, then there will be hypotension and tachycardia, or severe hypoxia can lead to bradycardia and arrest. Then once you have done thorough evaluation, then you will prepare the child and prepare the bronchoscopy suit. Regarding preparation of the equipment, the bronchoscopist, the pediatric surgeon, or the pediatrician, or the emergency physician will like to have all type of bronchoscopes suitable for the retrieval of the foreign body. So it is not my domain. Usually rigid bronchoscopy is still considered gold standard for retrieval of the foreign body, but with the advent of flexible bronchoscopy, we have been able to retrieve many more foreign bodies as compared to few years back. Now you will check the fasting status. If the child is not fasted, then you can do an ultrasound abdomen, ultrasound, gastric ultrasound, to see whether the stomach is full. If the stomach is full, you can put an NG tube and evacuate the gastric contents. Then definitely you will secure an IV line for emergency resuscitation if required, and during the bronchoscopy procedure also a IV line is a saver. Then anesthesia machines and breathing circuits will be checked. If it is a flexible bronchoscopy, then it can be done under sedation. If it is a rigid bronchoscopy, it will require full anesthesia. Do not forget to ensure that suction is ready with you. Then if the child is in respiratory distress, give some oxygen. Patient is not hemodynamically stable, start some IV fluids. If time permits, give some bronchodilator nebulization or inhaled steroids or IV steroids. Do not forget to take consent and discuss the risks with the caregivers. What are the risks? The usual risks are laryngospasm, bronchospasm, hypoxia, desaturation, and sometimes pneumothorax. And there can also be trauma and bleeding. All these risks should be discussed in detail with the caregivers. Then the next point is procedure sedation. As I told, bronchoscopy can be done under local anesthesia and some sedation, but rigid bronchoscopy almost always requires full anesthesia. The aim of providing anesthesia or procedural sedation is to prevent any kind of movement, laryngospasm and coughing, and to maintain oxygenation and ventilation throughout the procedure, to prevent hypoxia, because in children if there is hypoxia, there will be bradycardia and there will be cardiac arrest. So almost always you have to ensure that the child is not hypoxic. Then also Giving full anesthesia will minimize the complications like airway trauma and pneumothorax. Now, anesthesia technique, I will not go into the detail, but general anesthesia is usually induced with inertial induction with sevoflurane or IV induction with propofol, and anesthesia is maintained with propofol infusion or dexmedetomidine infusion. Dexmedetomidine is a new drug which blunts the airway reflex perfectly, and it do not cause respiratory depression. So now in modern anesthesia practice for foreign body removal and bronchoscopy, it has come in a bigger way. Almost all the anesthesiologists are using this dexmedetomidine infusion. Muscle relaxations are usually not required. We would like the child to be spontaneously breathing, because if you are giving positive pressure ventilation, then there is a chance that the foreign body may enter deeper into the airway and it makes difficult for retrieval. Then the bronchoscope acts as an endotracheal tube here. If the child becomes apneic, we can give oxygen. If the child is not breathing properly, we can give positive pressure ventilation through ventilating ports in a ventilating bronchoscope. Sometimes in my PG days, we were using jet ventilation during anesthesia, but now it is no more used, and it is not a painful procedure, but analgesia is required. Usually we give fentanyl boluses. Then monitoring, routine monitoring. This procedure do not require any special monitoring. Routine monitoring, like as of all of you know, SpO2, heart rate, blood pressure monitoring, end-tidal carbon dioxide, and precordial stethoscope is good enough for the safe conduct of the bronchoscopy. And during bronchoscopy, the anesthesiologist is very much aware of aspiration of the gastric content into the airway, which can be prevented by good suctioning by the bronchoscopist. Trauma and bleeding is always a complication, so the bronchoscopist has to be very gentle while removing the foreign body. Then there can be pneumothorax. As I already told you, laryngospasm and bronchospasm are very common. If the with normal sedation there is laryngospasm, severe laryngospasm and bronchospasm, and the child has got a very reactive airway, then sometimes we have to paralyze the child. Most of the time, we do not paralyze the child. We try to maintain spontaneous ventilation. Then post-procedure care will be taken in detail by Dr. Krishna. I'm not going into the detail, but after the foreign body is removed, the child should be shifted to a high dependence unit. He should receive bronchodilator nebulization. He should receive steroids and adrenal nebulization. Sometimes some bronchoscopists, they would like to administer antibiotics. So coming to the summary, rigid bronchoscopy is still the gold standard. It requires full general anesthesia. It is a shared airway procedure where a very good planning and coordination is required between the anesthesiologist and the bronchoscopist. And spontaneously breathing patient is always a better patient. It prevents further moving of the foreign body deeper into the airway. Then it becomes really difficult, but it is not always possible. Positive ventilation may be required in children with highly reactive airway to prevent further airway complications. So full GA is always required for rigid bronchoscopy. Flexible bronchoscopy can be done under sedation and local anesthesia. Thank you. Any questions I can take, or we can take the questions during I'll be glad to take any questions. Or else we can move. Please, sir. Can somebody give a mic?
In every part you have discussed almost everything, and there's hardly anything left for the rest of the speakers to speak. But in every segment you have spoken, like presentation of the patient, the clinical examination, the imaging, the preoperative preparation, the procedure with anesthesia, monitoring during the procedure and the procedure itself, then post-operative monitoring, and what are the different complications you can face before surgery, before endoscopy, during endoscopy, and after endoscopy. There are comments to be made in every segment. So I don't know how to proceed with it, but as a beginning, I may say that while a patient present with history of choking, history of uncontrolled cough and cold, which is not going with antibiotics, and a patient who has reduced air entry on any part of the lung. And I must emphasize that you must listen to the chest with the patient not crying. If you listen to the chest with the patient crying, often you will miss the reduced air entry on any segment of the lung. So you have to be quiet and you have to be patient to examine the patient while he is not crying. And history of choking, history of unresolved cough and cold, and history of, and finding of reduced air entry on a particular segment of the lung are very, very suggestive of a foreign body aspiration. And in the imaging, yes, really, I have got 6, 7 slides of nails, screws, many other things inside, and you can see. But one thing I must say that the amount of respiratory distress is far less if the foreign body is in one of the bronchi, because the rest of the lung will take care of the breathing. But if there is a foreign body in the trachea, the distress is disproportionate, and that child may die if the foreign body in the trachea gets dislodged into the larynx. So those are the patients who need early intervention. And the third thing I will like to emphasize is that you have written age of presentation for foreign body 0 to 3 years. 0, no way a foreign body can go in. Maybe 3, 4 months when the child starts crawling and start putting things in his mouth. So please change that to 3, 4 months to maybe 10 years also. Second is differentiation from a croup in an infant. If there is a croup, the patient present exactly the same way. The whole distress started suddenly and the child is in severe distress. But in a croup, there will be no reduced air entry at any particular segment. And if you treat the patient with nebulization and maybe steroid, the condition improves dramatically. So in a croup, if you end up doing a rigid bronchoscopy, even a flexible bronchoscopy, the condition will be perpetuated. You'll get into a bigger problem. So you should be careful. So far regarding presentation and examination. There are many other comments in the other segments. We'll do that when we come to the plan.
Thank you. Thank you. Any questions? I would like to take some questions. If any doubt. Sir made very nice comments. Thank you.
You can take question during the
During hands-on, we
during
can take the
hands-on.
questions.
Okay.
And we can also discuss with sir.
Yes, yes.
Okay.
Yes,
Thank
yes,
you.
yes. Thank you. Thank you, Basu sir. I'll next invite Dr. Sanjay Rao for surgical anatomy of pediatric air beta. Thank you, sir.
So the difference between what happened in the morning and what's happening now is this is a workshop. So here the more talks should be from your side rather than us standing and giving you didactic talks. So I think please participate a little more. So how many of you are trainees? Sorry, that light behind is so bright. About 50%? Is that reasonable? Yeah. So between the trainees and the consultants who are here, how many do bronchoscopies on a regular basis for diagnosis and foreign body removal? Dr. Basu, yes. Who else? Anybody else? Yes. Please come in. More the merrier. So relatively few. So 50% PGs. How many of you PGs have seen foreign body removals? A good number. Okay. And so in the consultant lot, few people are doing them, not very many people are doing. Okay, that's the reasonable assumption? I can't see you all because of those lights.
Registered, not registered.
Okay, so now what we are going to do, the idea of this workshop was basically to train you to do just diagnostic scopes, simulate some foreign body removals, and also understand airway anatomy. See, ultimately we are surgeons. So we have two responsibilities. The most important responsibility is to make sure that the child's airway is safe. You might have a situation where you cannot intubate, or you have a foreign body, or you have anything, trauma, whatever it is that you have a problem with the airway, you are not able to stabilize. So that ultimately will come to your lap, and it should come to your lap. It should not go to the ENT surgeon. All right. So we need to understand pediatric airway, and we need to understand the surgical anatomy of the pediatric airway, and we need to be able to do endoscopies, and we need to understand the endoscopic anatomy. So the way this was structured was a bit of an overview. And then you will have an anatomy of the endoscope, of how it looks when you do flexible endoscopy. And then we will talk a little bit about the surgical part. So I will concentrate on the surgical bits. That's what I'm expecting to do here. Is that all right? In any, yeah? Yes, no, thank you, bye. Kuch to bolo, it's getting one-sided. Sorry, how do I open this? Folder is empty, bol raha hai. Okay, so what we will do is I will talk to you a little bit about how a child's airway is. The thing that surprised me most was how small things are. When we do dissections in anatomy, during anatomy dissections, they are adults and everything looks very big. The trachea is a big structure. It's a robust big structure. Everything looks very big. I don't know. There was a big series of YouTube videos that were done by an ENT group in the US where who's the lead singer of Guns N' Roses? So there was an endoscopic video of him vocalizing. His vocal cords are huge. You can actually drive a truck through that. It's that big, you know, huge. And he cooperated because he had therapy, and then you know how the voice changes and things like that. So when you look at that, you think everything is very big, but actually things are pretty small, and even small degrees of rough handling can make a bad situation much worse, simply because of the edema you can create and the hemorrhage that you can create. So it's important to understand that when you scale down to a child, everything becomes much smaller than you imagine it to be. Unfortunately, we do not have pediatric mannequins here, but just imagine that, and I will try to give you some reference points. So how does the infant airway or the pediatric airway differ from an adult airway that we are all very familiar with, that we dissected and we did everything when we were medical students? All right. Now the airway starts at the face, and the mid face in a child is often very small. They have predominantly large foreheads. Their mid face is quite small, and for mid face development usually takes a very long time. And that's why even those who do cleft palate surgery routinely will tell you that if you are rough when you do the cleft palate surgery, you might damage the anatomy and you might end up with having facial problems. So the mid face is very small, because of which the nasal passages are very small. And if you try to forcefully put tubes, forcefully put nasogastric tubes, etc., you can cause injury, you can cause swelling. And because a lot of these children are obligate nasal breathers, they will obstruct. So the mid face is extremely small. In addition, the tongue is pretty large compared to what it is in you and me. So the tongue can cause obstruction. In addition, they have a lot of lymphoid tissue in the tonsils, and more so in the adenoids, and they tend to develop viral infections frequently, and the adenoids can be quite large. You try to push some tube down that, you will traumatize, you will have bleeding. So please be conscious that these are things that do not matter very much when you are big, but when you are small, they are very, very important. Now, all of us know that the next thing that you come down to is the larynx. The larynx has many functions. It is imperative that you have a normal larynx to live outside the uterus of placental circulation. All right. It has various functions, some that are obvious, some that are not so obvious. It's worth reiterating. It is a conduit for breathing, because if you have laryngeal webs or laryngeal atresia, you cannot breathe. So it does, it helps you breathe. The larynx is also important for feeding. If your larynx doesn't work very well, you will aspirate and you will have problems. So larynx is important for feeding. It protects your airway from aspiration. So you need a functioning larynx. It initiates cough reflex. So it protects your airway. And it's also important for communication. So I'm talking to you because my larynx is functional. So the larynx has many functions, and preserving larynx is very, very important. The commonest injury that you get here because of forceful intubation. So please be conscious when you intubate patients, because the first step of any access to the airway is a safe intubation. If your intubation is rough, you will have problems. So your intubation must be safe, and for that you must understand that the larynx is very important, and structurally it is quite different from adults. The one very interesting thing how things have evolved is that this is probably the only part of the human body where two separate passages meet and then separate. So your breathing passages and your feeding passages become one, and they separate again to become two. So there is no other part of the anatomy where two separate streams, fecal stream, urine stream, air stream, blood stream, they do not meet anywhere. So this is the only part, and why that has evolved like that is something that, we don't know. Maybe there are theories, but this is something that is unique to this anatomy, and that is something again that we must realize, that you have two passages becomes a single passage and then again becomes two passages. So please remember this will come back again. Now, if you look at this when you start and you look at the anatomy of the airways, as I said, in an infant, the midface is very small, tissues are very loose, there are prolific adenoid tissues, as you can see. Again, in children, they have large heads, short necks, and because of that, their larynx is placed very, very high in the neck. So when you and me and you are well chiseled, you can see your Adam's apple about 4 finger breadths below your chin. Whereas that's not the case in a child. So their necks are very short and the larynx is put very, very high. And as you can see, the higher you go, the more like the younger you are, the more higher. Is there a pointer? The more high is the larynx. Now coming down is the laryngopharynx. Now this is again a very, very important structure. You must understand that we have a uvula which is coming from the palate, that comes from the top, and you have the epiglottis that comes from below. All right. And when we are swallowing, these two structures in a child are often overlapping. All right. So once that happens, the food that you swallow, the milk the baby swallows, splits. It's like having a rock in a river. What happens? The water comes, it splits, and it goes round. So similarly, the milk comes, is split by the epiglottis. From the epiglottis, it falls into the pyriform recess, goes behind the larynx and enters the esophagus. So this swallowing mechanism is important in children who have caustic strictures, for example, or children who have scarring in their larynx. This mechanism doesn't work and often they aspirate because of that. So this dynamic thing is very, very important. When you flex the neck in a small baby, simply because the larynx is so high, you tend to get airway obstruction. That's why always it is said, when you nurse a child, please nurse the child with a little bit of extension. Going further down, the epiglottis, all of you are aware, in you and me, it is more like a shield-like structure, whereas in a child, it can be curled. It can be like an omega. So it's very, very curled. The epiglottic fold, that means the fold that go from there to the arytenoids, are very, very short, and because of that, sometimes this epiglottis actually falls on top and can cause obstruction. So supraglottis is very, very narrow, very narrow. Now this is the difference. So if this is the adult larynx, as you can see, that's the arytenoids and the long vocal processes, long vocal cords. So it's very easy to intubate without injuring anything here. Whereas in a child, about 50% of the vocal cord is made by the arytenoid process. So if you traumatize this, you injure one of these arytenoids, they get dislocated, your vocal cord is fixed. So it's a very, very short kind of a gap, a glottic gap in a baby. This is an important slide. Again, as you have repeatedly been told, the narrowest part of the pediatric airway is, come, students. Narrowest part of the pediatric airway is, cricopharynx is a big area. Subglottic. Why? Why is that the narrowest part? The cricoid cartilage is the only dash cartilage in the entire airway. Complete cartilage is the only complete cartilage in the pediatric airway. And that is why it is the narrowest part of the pediatric airway. How is it important? What is its clinical significance? Clinical relevance? you usually use uncuffed endotracheal tubes in children because the seal is provided by the tube against this ring-like cricoid. In an adult, they will use cuffed endotracheal tubes. Pediatrics, you generally don't use cuffed endotracheal tubes. You use an endotracheal tube that is uncuffed because you rely on the seal between the cuff and the cricoid cartilage. Okay, so the cricoid cartilage is a complete circle. It's the narrowest part. So the whole larynx is like a funnel. It's broad on the top, and as you go down, it becomes narrower and narrower. And the narrowest part is at the cricoid, as you can see, which is a full ring. Now, again, if you look at these structures, when you feel your neck, what are the typical landmarks that you feel in the midline of the neck? Again, students, what's the main important? You do this when you palpate for thyroglossal cysts, etc. What are the structures you are palpating for? Hyoid, okay. You need to speak up. More than thyroid cartilage, thyroid notch, okay. Thyroid cartilage, hyoid, thyroid cartilage. Next structure, midline, sternal notch, okay. So usually you feel the mandible, then you feel the hyoid bone, which is quite high up in the neck, then you feel the thyroid notch, then you feel the sternal notch. So all these structures have to be one line craniocaudal, okay. So you find the mandible, then you find the hyoid, then you find the thyroid, then you find the cricoid. These are craniocaudal in axis. They are up to down. Whereas if you go to a baby, see what happens here. Your mandible is there, the hyoid is there, the cricoid is there. So in a normal resting position in a baby, the structures are all more or less horizontal. All right. So especially when you are trying to access the neck, say to do a tracheostomy or you are trying to intubate, you must remember that the lay of these tissues are different. How these things are organized are different. So please be conscious, and this is a very important picture. And every time you think of anything in the neck, whether you are doing a neck dissection in a small baby, you are going after a lymphangioma in the neck, for example, a large cystic hygroma, you go to operate, or a cervical teratoma, you go to operate. You have to be conscious of the anatomy. It's not in this order. They are all one behind the other. And that's the reason why if you are rough in the way you dissect, you tend to cause injuries. All right. So please remember this picture because it will come back again to haunt you. All right. So as I said, why are these things important? These are important because as far as you are doing endotracheal intubations, remember that when you are trying to intubate a child, the larynx is high, the larynx is small, and often there are things that fall in. You know, the tongue might fall in because it's large, the tonsils might fall in because they are large. So you must be able to position your laryngoscope in a way that you have access to the larynx. You cannot put that laryngoscope inside and try to shove the tube in. You must have good visualization, and for that, understanding anatomy is very important. Similarly, when you are doing a tracheostomy, it is very important. We will talk about tracheostomy because I think as surgeons it's very important because often it is the port of last call. You know, you have to be able to do a good safe tracheostomy. You might not need it, but when it is required, you must be able to deliver, to your, you have to do it properly. So that's why it is important, because what landmarks you usually feel in an adult, you will not be able to feel in a child. So we will again talk about this as we go. Now, as we grow, things grow rapidly. For the first 3 years, the length grows, the width grows, everything grows, and that's part of the reason why you wait. For example, if you have some laryngomalacia, you wait for some time because things tend to grow and get a little stronger. You have a small hemangioma, you wait because over time it might get better. You have a minor degree of tracheal stenosis, you wait because often it tends to grow as time passes, and growth continues till adolescence, and it's around that time you start to get adult dimensions. Trachea, again, we are familiar. Trachea is a D-like structure. About 4/5 of the anatomy is cartilage. About 1/5 is muscle, and this allows the trachea to change its diameter. And because it can change its diameter, it can change the amount of air that it can handle. For example, when you are running and you need more air, it can open up to allow more air to pass. When you are coughing, it can contract, create enough pressure for you to expel the air vigorously when you cough. So this is important. So when you have laryngomalacia, for example, this 4:5 or 4:1 ratio changes. You might have a 3:2 ratio, in which case there is more soft tissue, and that soft tissue tends to flop about, and laryngomalacia or the tracheomalacia becomes symptomatic. All right. So this is the anatomy, and this is, well, all of us know this. This is standard. Now I will draw your attention to this slide because this is important. Now this is a child who's between 0 to 2 years of age. And if you look at the length of the trachea, it is 5.4 centimeters on an average. And its diameter is about half a centimeter. So how big is it? As big as your little finger. All right. So you can imagine our impression of a trachea is this big structure that is sitting in the neck and the chest. It is not the case. In a child, it's a very, very small structure. It sometimes is as big as your finger. So especially when you are handling this area, say you're dissecting in the neck, you're doing a tracheostomy, or you're dissecting a large lymphangioma or a large teratoma, please be conscious that you're dealing with very, very small tissues. And it takes time. Even at 8 to 10 years, it is about 8 centimeters in size, 8 to 9 centimeters. So it's a pretty short structure, of which about half is in the neck and half is in the thorax. As you grow older, more and more of it gets down into the thorax. So it's a pretty small structure. Again, this is the common age group for foreign bodies, 2, 3, 4, 5, 6 years. The diameter is hardly 8 millimeters of the trachea. So any injury to the trachea, if the mucosa gets edematous, your cross-sectional area will come down. Any idea what that formula is? Diameter versus cross-sectional area? Homework. So the trachea will start to grow as you grow older. So initially it is pretty small, very small structure. And that's something that strikes me amazingly every time we do something in that area. It's just such a small structure. So again, I think we will finish this quickly. So as I said, normally the flow is laminar. There is no turbulence. The turbulence comes when there is a change or rapid change in diameter. The cross-sectional area usually changes. Today there is beautiful dynamic imaging. Dynamic MR gives you, it's like seeing the child swallow in 3 dimension. It is like seeing the child breathe. You can see everything moving. Otherwise, we were relying basically on fluoroscopy. We are relying on other dye studies. But dynamic MRs today are beautiful imaging for this. So if you are looking at something and you ask your MRI colleagues to show you some pictures, it's beautiful. You can mimic a lot of these things on real time on the MR. So normally the cross-sectional area changes 10 to 15% at normal respiration. When there is a cough, more. If there is a constriction of more than 50% when you breathe, when you inhale, if your trachea is constricting more than 50%, it is sort of roughly called tracheomalacia. So for take-home message, pediatric airway is much different from adults, both structurally and functionally. And these implications for us as surgeons are very important, both from an endoscopic intervention perspective and from external neck operation perspective. So please remember that. And aware of this is very important because routine procedures that we do, putting nasogastric tubes, putting endotracheal tubes, putting temperature probes, all of this can cause significant trauma and injury to these patients who are often critically very, very ill. So I will stop here and we'll go on to the next briefly about doing a proper airway assessment. Again, there are 2, 3 components to this. I will, so you usually do what, if there's a serious airway condition, you do a triple scope as it is called. You do a proper airway assessment, you do a microlaryngoscopy, bronchoscopy. You will do a flexible bronchoscope because that will allow you to go further down the bronchi, collect BAL, do all those things. And you do an upper GI scopy if you think that this child has reflux or fistulae and things like that. Again, we cannot overemphasize the importance of history. I think it was mentioned previously, Dr. Basu mentioned it. I think history taking is very, very important. And once you finish the assessment, you must have a plan in place. Yes, I have a foreign body, I have to take out the foreign body. Or I have this particular anatomy, or I have a stricture, I need to manage it in this way. Okay. You have to have synchrony and harmony with your anesthesia team because they are the guardians of the airway. They protect the airway in 99.99% of surgeries that you do. So for them to allow you to go and do things, especially in a child who's got stridor or breathing difficulty, it takes a leap of faith for them. So you have to look at it from their side. All right. You are asking them to give this child who has a precarious airway to you, the surgeon, who doesn't come up 99.9% of the time. So please build rapport with your anesthetist because it's very important. Otherwise, each of you will die a very rapid death. Okay. So please, it gives you will get heart attacks quickly. All right. So please have good relationship with your anesthesia team. Again, it was reiterated. Most of the time, we like to do this with the child spontaneously breathing. We do not paralyze, unless there is some overwhelming reason to do it. I think the next speaker will talk about flexible scopy. So before I wind up, I will just tell you about why we do rigid scopies. One, because it has excellent optics. Today, the flexible bronchoscopes, without doubt, provide beautiful images. The chip-on scopes today provide you excellent images, but still there is a limitation because of the size. But even compared to the best flexible bronchoscope today, a rigid scope provides you better images. So as far as possible, a rigid bronchoscope gives you excellent images. There is large magnification and you can see finer details. Okay, so that's why sometimes it is useful. The greatest advantage is your ability to ventilate during the process, which you cannot do with a flexible scope. So you can have the child safely asleep. You can be ventilating the child through the bronchoscope and you can do the procedure that you need. So there is a larger degree of safety. All right. It is a straight scope. It has a wide sheath. So it is easier to handle more instruments. You can put bigger instruments. It's easier to take out things, put things, suction, especially if you have blood and things in the airway. It is important. So it is always safer, with a rigid bronchoscope. But there are some disadvantages. The disadvantage is that, as was mentioned, you do need anesthesia. You cannot do it with an awake patient, and you cannot assess beyond the main bronchi, the second, the sort of the first, you cannot reach beyond the second degree bronchi. So for that you need a flex scope. Okay, plus the right upper lobe bronchus is inaccessible. You cannot look up because its direction is completely different. I'm sure you will see it as you go. So this is our usual tray. So there are a whole lot of instruments on that tray. We will be discussing about these ones today because they are related to foreign body. Some of them are endolaryngeal instruments. So we will talk about these, and these are available here. So we will discuss them as we go forward. So I will stop here, and if there are any questions, we can take them. Otherwise, we will move and we can address them later. Make some noise, make some noise. No noise. Hey, not that.
Not clap.
No claps. Please ask, talk.
If you have questions, just ask. Otherwise, we'll start
we'll
the
go to the next
hands-on
one. Yeah.
this thing. So let's
Yeah.
divide now. I think we have yeah. He will explain. So we have 22 registered delegates, and the audience is more than that. So I believe uh, cannot accommodate more than 22, maximum 2, so 24. So 6 in each this thing stall. So this side is rigid bronchoscopy by Storrs, okay, and this side is flexible bronchoscopy by Olympus. So you divide into two groups. So I have the names. So do you want me to call out names and divide, or like you will self divide yourself? Those who are registered are prepared. So I did not to force anybody to work out. So please divide yourself. That will be better. Okay. So like 45 minutes of session, because it will otherwise go on. Okay. So 45-minute session. After that also there are session. So will please sit. Please come. This we'll see. So divide yourself in. Yeah, flexible to this side, rigid to this side, please. देख लो देखना है तो it's very difficult to मतलब I will let you know. That's way. If he can allow you, he's the master of science. So we have less space also, so please be accommodative for everybody. Yeah. हाँ yeah. Flexible bronchoscopy, please come to this side. We have two excellent faculties who can teach you more. Please come to this side, flexible bronchoscopy. Because after 45 minutes you have to switch sides. It's not like that you will be sticking to one place. ये तो अपना ये बोलता है कॉन्शियस बोलता है कि नहीं मैं रजिस्टर्ड नहीं हूं तो नहीं आना चाहिए आ गए क्या करें धक्के मार के थोड़ी पिक्चर्स ले लेना सर समझ पिक्चर्स
This is called the sheath. Now this sheath, has certain parts. So one of them is placed here. You get your telescope. Telescope is inside the camera. All right. There is another side in this here which carries one of the legacy. What was there? That's the reason it because this has a pyramid. So what used to be done was so so the light source from there is that you will attach your light cable here and the light would come at the proximal end of your phone and you would expect to see down there. Fiber. So now legacy the body you have but here so if you click it now, you can actually see the come inside the camera. Right, so see the light and you can see along with it. But imagine keeping the light here there, it's surely not very effective. So the user this were normal English compared to the it's not getting anything. She sort of put the side event in the sort of calculation something over there but that is now small now we have optical. So this basically is only for this this other channel is involves your ventilate the standard now when you go down this so this side will work even if the changing software you can still get that. It will stay at the right from the main that is why there is a standard question that is asked how do you differentiate bronchoscope from elastonoscope or esophageoscope? But they don't have it. So you don't have that. That is what we want. The other thing that they are why do you think you don't? If you look at different countries, and I don't know, all down that they get it like they have the right side or the left side. Right side, why? It's better, it's bigger, or it's like so if you have to enter the left side is an angle bit. This is a rigid instrument, cannot play. So what you do is you come to this junction, and if you use this divided slide, Yeah, in the left one, the light, in light, actually, the colors are given in that channel one. Also, we have actually put down. The light given to get given. In there, extra that way, that is the reason. There is one more connection we have connected connection usually there are three sides. So all these nodes we have actually thought around the vaccine model is they will actually align the table with it or they this is or want to do that. Usually you not but other things really because you do function. Not this is a very small it shares standing with the telescope. The ideal thing for us, where ideally very well for the good way to do it. Otherwise, it's not very small. We have to take out the scope of whatever. So that's true. Again, the battery sometimes doesn't quite come the telescope for us, but you can not very common. It is periodic with but that is very often have both very oftentimes we have to go out and take out the scope. The year. So whatever outside road. They will discuss their like the art of the first response and what our telescope so they were not the telescope is not the same size as photo. All the telescopes for the bridge we cannot ventilate the chip, but they have already got basically it is how you can adapt and cannot ventilate and allow the telescope go inside. So you have a bridge. And that is all these things that are and why is it important? Because the diagnostic but not wanting to become like that. Not becoming here in but at the same time, when you actually everybody extraction. There's no one light is carried by optic or you put an element, light is carried by optic. What is coming out is coming through your that's why we do bend from the the bending to take to go then take your campus points and put it on glass. We get a have to go on tissue to you know the thing or you do not table or the glass. It is really that because the fiber that carries the and coming back to the water glass. Again, you have the zero marker that you have it split. So that will be so not generally most people who are ask me about what do you practice? Those who are interested because coming in and then all the time for all the now, any of the not wall but when you walk into it, we want to check the end of the now, the next instrument that we are basically all this these are optical for the as I told you, the older case forces did not have optical. They were blind, they were dead. You can might not think. One down, nothing. Fishing out that rapidly, or you play that all in the day before you do. Now you change those parameters. So that's what we learn for the poem. See what is meaning. That is what once you do that, now you are doing something. But it is important that they have in that if they become deep, they become acting at the saturation. I think that's why it is important that very, very different. So now everything is stable, the patient is ventilating. It's our right side, the left side is nice, you cut everything out, everything is stable. Once that is done, then you tap this. Then you take whatever you put down, now that it is a peanut, you choose your peanut for there. Camera, yeah, that's the biggest problem because when you use camera, every time you have to change the camera from front to back. It is under vision. Go to the foreign body. The ideal thing is to go around the development and work over. Try to see which way is the most easy to go. Sometimes if you are like what is half a peanut from the India board is not direct to it's narrower than what is in the border. This time whichever way. Try to grasp it gently. Bring it to the end of this because commonly foreign bodies will not enter the sheath. They're bigger than the sheath. Then you take a pump, bring it here, under vision, put on the bone in pump. Okay. Other part that this will get rapidly movement with that. Some of the things they have to be you're taking it out, you have to especially careful that it gets hot. If it gets hot, again put your shield sit down, stabilize, then take it up. So that is how once you do it, what you do another scope, both sides, other than you are not eventually follow it again. Come on, that's very I think yes, it doesn't happen quite often. I try to make a very top forward what is it doesn't happen. You can break it out. One problem comes with this hard. Example, equilibrium, they are very difficult for speed because they are very difficult to hold. It could be sometimes average speed, sometimes all the time they hold it there. So speed is it. So they are difficult. You have to keep on doing that. Speeds are difficult. So they are spreading that you cannot hold it. So then gap sometimes are difficult. Sometimes the other way around where the convex surface is facing one edge and opposite on. Either side on. Then in that case, you don't have to the right whatever. Maybe that's like right. people are trying to provide it from the pole is the B and then flow the power to the other side. So here all the already done. There are cases that are back. And then sometimes you really have a problem like you have to bring the fire here, hold it there, and open that break here. I want to protect the airway to the by hand to the hand. It's a really big point that we have right now. I don't know because of the 12 they go in, they get the out, so there is a wire. It is not our wire things that were important as it is, or if you have out there, it is now. The other thing is the airport, right? Okay. Yeah, or you're here. So, triangle it does solve the problem. The nucleus is very small. The region is large. You need a big better to take out and the same. So we have to score. We have one here. Doesn't take a hard work. When I go with the lens are yeah, there is scope shot. All time and back at the working time one figure on the art palette for both the factor. Then they play on the book, then they start to document. So obviously on the top, slide the right, is playing of it.
फोटो खींच ले पहले तुम वो बस जाता है स्टार्ट ये दूसरा बार लाए तो अटन Okay, I have an announcement. Like which whoever want to switch the sides from flexible bronchoscopy to rigid bronchoscopy can do right now. Okay, we have another 40 minutes of hands-on. Then we'll have two more short lecture. Then we'll finish because it's already time is there. Stick to Sanjay Rao sir. Huh? So the second session starts from now, 45 minutes. Please switch the sides. Second rigid bronchoscopy session starting. Those who want to join, please join. Sanjay sir.
The whole thing over time will just and you can like have this continuous and there will be for example, you want hospital again, there are a lot of there is people not we don't know what to hope you can they will that again they know it other not that started and the murder I was actually Always keep it in mind. You know the site we will. One more. When you have to move to the right side, use this hand to turn the neck on the left. Turn the slope physically to have the side. Similarly, with your flick the left side, turn the right. You move to the right. Anything. खाली रहता है ऑप्शन में ये प्रॉब्लम है एक्स्ट्रा दूसरा ऑप्शन है कि दो अगर they can continue with their
I have one announcement to make. So we have two more lectures like post-procedure care and handling of complications by Krishna and Dr. Vikram, Dr. Krishna and Dr. Vikram, and then indications and how to do a safe tracheostomy by Dr. Sanjay Rao. Then question answer session. So we will stop in 10 minutes and we'll start the lectures. After the lecture finishes, you can still continue to practice on the mannequins. We will have it till evening, late evening, so you can practice. So in 10 minutes, we should start the lecture. Thank you.
Chair will my presentation is tomorrow. So preview.
but tomorrow early morning you come, then we go back.
Edit नहीं किए तो
Better to like last week. ये वाला लेक्चर चालू होगा
procedure care and handling of patient. Here, check कर देंगे सर। यही PPT है उसको आप नाम हाँ वही बस care and हाँ यही हाँ
सर याद है हाँ मुझे बताया था सर मैं बता दूंगा सर
नहीं नहीं
लास्ट 3 स्लाइड
PPT है
पीपीटी है
कौन सा वाला
हाँ हाँ यही सर लास्ट में कर लीजिए लास्ट 3 ये है ये तीन हाँ हाँ ये दो स्लाइड है सर बस इतना ही है 1 2 3 बस 1 2 3 बस दैट्स इट
प्लीज
तीन स्लाइड ना मैं
अच्छा ठीक है मैं बोल दूंगा फिर उसके बाद सेम प्रैक्टिस करने वाला संजय राव ठीक है याद रखो हाँ सर पहले साल में हाँ ये पहले
delegates are asking कि dinner पे अगर कोई non-registered है
So we'll stop here for some time. We'll have the lecture. Then we'll continue with the practice. Okay, Krishna, Dr. Krishna. I think we'll start with the presentations. Then we'll continue with the demo later. Please be seated. Please be seated. Please be seated. Huh. Please be seated. Let's finish it in time. You can continue to practice after the sessions. No issues. We have it till late evening. Okay. So now we will have the session on post-procedure care and handling of complications. It will be covered by Dr. Krishna Mohangulla. Okay, you can start.
Let's start.
Please be seated. Silence, please. Please be seated.
So I think this will be the repetition of what we said. That's the reason I will keep it very simple. Only 2-3 slides. I don't bore you much. So what you are when you are doing any procedure, you need to have this type of monitoring. One, you have at least ECG, pulse oximetry, and blood pressure monitoring. So others are ET, CO2, hands and pulse, chest observation, stethoscope. Nobody does. Especially these things. So who will look at the pulse, what is happening, and who will look at chest, what is happening? Who will auscultate? You tell me how many percent of surgeons do auscultate during the procedure? I think it is 1 to 2%, not more than that, 1 to 2%. So none of the surgeons do auscultate, right? So just you make it a habit that you try to auscultate and identify that aorta is reduced or not. This much is okay. We are not asking you to identify vertical breathing or, or amputated breathing. We are not expecting from surgeon, right? So at least first 3 you need to do: ECG, pulse, and blood pressure. So remaining plus or minus okay. Now after that is the most important. Everybody, the server saying after the removal of one, but everybody do clapping and then everybody will go out. This is what is happening. So after that, the remaining everything to be cleaned by the anesthesia resident or our resident. Or something happens, if in the post-operative teams, if something he had hypoxia, arrest, then only we will come in, we will enter the scene. This is what happens. So obviously the most important is we take care of before and during procedure, but after procedure the most neglected part that needs to be taken care of well. And look for any, because you are doing a lot of manipulation, they may have stridor that you need to look at, and there may be some amount of bleeding, or it is if a lot of spasm is there, it may cause sudden cyanosis also. So these things we are supposed to look at, and always keep the patient in the lateral position so that the aspiration risk may be a little bit less in the recovery room. And ask the patient to take do not take anything orally until 2 to 4 hours after the procedure, so that the aero reflexes. Sometimes what happens, the child may be awake, but because we give lignocaine, it causes anesthesia, anesthetize the laryngeal area. So even the patient might be able to normal sensorium. If we give, there may be because of the poor sensations, there may be chances of aspiration may be there. And other is always the patient is alert, talking. When he comes back to the pre-sedation level, then only we will go for allowing the patient orally. And complications is very routine or minor complications. When you put through the nostril, you will have nostril trauma, epistaxis, dissociation hypoxemia, cough and bronchospasm, and you may have airway trauma and edema, that's what I said earlier. You may have pneumothorax, and fever is one of the most common. This is one of the after bronchoscopy doing BAL, we commonly encounter the fever because when you put saline there, it will cause a lot of inflammation there. So it may transient cytokine and can cause fever. Usually it settles down within the next 24 hours or so. And infections, if you do not, even though you say that it is not bronchoscopy, not a complete cerebral procedure, it is a semi-cerebral procedure. So because when you put the scope to the nostril and it will go to the bronchi, so you will definitely some amount of infection may be there that you need to take care of. That's it. If anything doubts, I can happy to answer. So only thing is, I request surgeons to auscultate. I request surgeons to feel the pulse and look at the patient after the procedure and look for anticipate for the complications. These are the 4 things. Removal is not the only thing. It is not the only your duty. Your duty is to take care of the post-operative patients also.
Question on the question answer session, I think. I'll invite Dr. Sanjay Rao for indications and how to do a safe tracheostomy. After that, we will have question answer session, so you can keep your questions ready for that. Thank you. Thank you, sir.
So I think as pediatric surgeons, it is important that you learn to do tracheostomy, because many times a tracheostomy is a life-saving procedure, and tracheostomy, if improperly done, can actually cause more problem than benefit, right? So it's important that we learn to do a good tracheostomy. How many of you have seen tracheostomies? I think our audience has reduced by more than 50%. So how many have actually seen tracheostomies being done in children? Lots of you. Good. All right. So once this gets open, so I will just show you a few operative steps, which I think is important, which makes the tracheostomy safer. And then in case you have any questions, then we will take it again. So today, I think with the number of tracheostomies you do are probably not very many, but when you have to do them, I think we should be able to do them in the right way. All right. So we come back to this picture. As I told you, when you do an adult tracheostomy, you can palpate all these landmarks. You can palpate the cricoid, you can palpate the tracheal rings, and you can do a proper tracheostomy because you can feel everything, unless that patient is so obese and has got some sleep apnea and things like that, which are not things that we see regularly. But otherwise, in most of the time, or older patients, you're able to feel all these structures. And I told you again, like what I mentioned last time, that is why the surgical anatomy of the neck is very important. Whereas in a child, it is often not possible to feel all these structures because they are sort of one behind the other rather than one on top of the other. So positioning the patient is very important. So how do you position a patient for tracheostomy? All these we saw earlier. So you position this patient with a good head roll, with a roll under the chest so that the neck is well extended. You don't want to hyperextend, but at the same time, there should be a reasonable extension. So there is a good gap between the sternal notch and the chin. You must have a good gap there so that you can then feel your structures. All right. Now, the standard instrumentation that you would use are basically basic surgical instruments. It's good to have 3 small retractors like cat's paw or Langenbach's. You need 3 for the minimum. You will have Prolene sutures depending upon the size of the child, maybe 4O for an infant, maybe a little bigger one for a bigger child, and the regular forceps and instruments and things like that. It is useful to have diathermy, a monopolar diathermy and a bipolar diathermy if these all can be organized. Fortunately, today, majority of the tracheostomies that you do are elective tracheostomies. Emergency tracheostomy for accessing the airway today is a less common procedure. because endoscopists have got so good, the anesthetists have got so good that they are able to intubate most patients. It's very rare that you have to do a tracheostomy as a for a airway saving procedure. You usually end up doing air, for other purposes. Somebody is stuck on a ventilator for a long time. Somebody's got severe head injury. Those are the usual indications today. Okay. So this is how you set up. So these are the instruments that you need. As I said, good shoulder roll, neck extended so that you have enough space between the chin and the sternal angle, the sternal notch. Then you mark your landmarks. So as I said, the first landmark here, as you all rightly mentioned, is the hyoid bone. Then use the the thyroid notch. This is the cricoid cartilage. And this is the sternal notch. So each of these landmarks are palpable. Okay, so the highest one that you feel is the hyoid. The cricoid is well felt in children because it is quite a thick cartilage and it's very easy to feel. The thyroid notch is usually felt if you palpate carefully, and the sternal angle is felt. So you please mark all these before you start. Keep the head absolutely neutral so everything is in one row, one line. You start by making an incision. The incision is made sort of halfway between the cricoid cartilage and the sternal notch. Right? It's a small incision, sufficient for you to put retractors and operate. You don't want too big a incision. Once you do that, it is important to defatten the subcutaneous tissue. So this is something that is not usually taught when you are doing it, but it is useful. So take hold of a tooth forceps and take out all the fat that comes out. You will be surprised at the amount of fat that comes, because in a child the neck often has a lot of fat in it. And why do you do this? You do this because you want a clean field when you are operating. When you put the retractors, you don't want fat to be falling around the retractors into the field. You don't want blood to be oozing into the field. You want a clean, dry field. Okay. And that's the reason why you defatten. Once you defatten, the skin becomes thinner. Once you put retractors in the skin, nothing falls, no fat falls around the tube, around the retractors into the field. Your field remains clean. So what you need to see at the end of this is this layer of fascia, which is the deep fascia, which is investing the neck. That's what you want to feel. Once you do this and then you put your retractors. So once you put the retractors, you can see that there is no fat falling anywhere. Your incisions are clean and the structures are well seen. The next step is to hold on either side of the midline. Often you can see the fascia in between, the midline. Hold it on either side and cut the fascia. Once you cut the fascia, you get the strap muscles. Once you get the strap muscles, you separate the strap muscles by these retractors. Usually it is good to have 2 lateral retractors and 1 central retractor. This can either go down or up depending upon your exposure that you need. What this does is it stabilizes the whole field. It does not allow things to move. Otherwise, one person is pulling here, other person is pulling there. The trachea is dancing from one side to the other side. It's useful for both these retractors to be held by the same person. So they know how much they are pulling on each side. If 2 different people are using, you are very likely to lose the midline. And this midline retractor holds the thing in the center. So it doesn't allow you to move. So this is usually held by one person. This is held by your sister. And then you have the trachea that is standing right up against the wound. And this retractor also helps to bring it up to the wound. And because you have defattened, there is nothing falling in here. There is nothing falling from the top. There is no fat falling from inside. Your field is clean. And you must be able to see the tracheal rings. All right. So where is it taught? Where do you usually make your tracheotomy? Which ring? Yeah, so you don't want to go too high, because if you cut the first tracheal ring, second tracheal ring, the incidence of narrowing is very high. You don't want to go too down, because then the tracheostomy is somewhere else and your skin incision is somewhere else. So the usual thing is third, fourth ring. How do you identify? You can't count through that small hole. So you look for the isthmus of the thyroid. So the isthmus of the thyroid will be just there, and isthmus crosses at C2, C3. So you go just below the isthmus of the thyroid, then you are on the 4th cartilage, and that's a good place to do it. All right. So this retractor helps with all that the third retractor that you have. So once you have the area exposed like this, try not to burn it with bipolar and everything. Doesn't matter if there are a few blood vessels, nothing is going to happen. Then you decide where you are going to make your enterot. So that's the isthmus of the thyroid. Then you put stay sutures on either side of the midline with proline. So this stay suture should go around the cartilage. So you go above one cartilage, go around that cartilage, and then come out on the same side. So you now have two paramedian suture lines or stay sutures. What does this do? Again, it stabilizes everything. It doesn't allow the trachea to move, and this one acts as a retractor. It takes away the skin edges, so you can now and brings the whole trachea up towards you. So it is now easy for you to make the tracheotomy. In pediatrics, no U flap. The adults like to make a U flap. If you make a U flap in an adult, that area is going to get strictured 100% because there is hardly any trachea. I told you the diameter of the trachea there is half a centimeter, sometimes 8 millimeter, 6 millimeter. In that, if you take a 3 millimeter flap, that is going to narrow. So there is no need to take flap, no flaps. You just make a vertical midline incision, maybe one ring, two rings, if required a third ring, all in the midline. And then you dilate it, and then you place your tracheostomy tube in. Once you place your tracheostomy tube in, this is a this is a catheter mount. You put a catheter mount so the anesthetist can ventilate from outside. Make sure that both the chests are expanding, because if the tracheostomy tube is long and the patient is small, the tube will go down the right side. You will have no ventilation on the left side. So please auscultate. Please look more than that. You must have visible chest expansion when the anesthetist is ventilating the patient. So once you have good chest expansion, remember your patient is hyperextended. If you flex the neck, again the tube might go down the right side. So you have to be a little careful and make sure that your tube is positioned well. It requires to be a little above the carina, so both sides are ventilating well. Once that is done, you don't leave this tracheostomy. You hold it continuously. Let everybody else do everything else. Once that is done, only then you tape it and tie it. You must tie it so that the knot comes on one side. The knot doesn't go behind. So one long length, one short length, the knot comes on one side. So in case it has to be opened, you can easily open it. All right. In case the tube is blocked or it falls out in an emergency, you have to change it. So usually we bring it out towards the left side or right side, whichever side, one side. And then you tape those proline sutures to the chest, because these will remain. Suppose the tube falls out tomorrow, all you need to do is to hold these two proline sutures and lift up and retract. So once you do that, it opens the skin incision and the patient can breathe through that hole until you have time to put the tube back in. All right. So that's why these stays are very important, and we leave them for about a week or 10 days because by that time the tract matures and it's easy to recannulate. Okay. So you keep these proline sutures there. So this is how you do the whole thing, and then only you extubate the patient, take out the thing. So this is how at least we do and we teach. Yeah. So if you have any questions before that, so what do you do? Position the child carefully, palpate landmarks, defatten the patient, the skin stays strictly in the midline, use stay sutures, fix your tubes carefully. You can mature the stoma in high risk cases. Maturation means you take stitches between the skin and the trachea so that it allows the tract to be formed, so that there is less likelihood of having a problem if the tube falls out. If the tube falls out, all these things will move at different levels. The skin will go at one level, the tracheotomy will go at one level. It's very difficult to put the tube back again. So that's the reason why if you have a really high risk patient that you cannot intubate from above, say child has got a big mass or child has got an atresia or a laryngeal web or something that you cannot intubate from above, then you mature the stoma. You stitch the skin to the tracheostomy with 4 sutures. Okay. Don't rush without adequate support. Ensure that you have support. Somebody is monitoring the patient. Somebody is keeping the patient safe while you do the operation. Do not dig blindly. It's a highly anatomical procedure. You have to identify each landmark as you progress. Don't make a U flap. All right. Don't make a U flap come what may in a pediatric patient. There is no need. That purpose is served by your proline sutures. They make the U flap to prevent that thing from falling in. In an adult it's fine, but children the same thing is done with your proline sutures. And remove the UT tube once everything is settled down. All right. So this is where I will stop. If there are any questions, I think all of us can take them together. No, not the suture. The tape that you use to tie that. So if you take two equal size, the knot will come here. So you take one long and one short, so the knot comes on the side. The tape, not the suture, the tape. Yeah.
Between two tracheal rings instead of
Not
just
required. It to be
not
very
required.
wide. One tracheal
One
ring,
tracheal
that
ring.
those things are quite sturdy. Nothing will
Sturdy.
happen. Yeah.
And so the tracheotomy, just one ring would suffice.
No, so one ring will be small.
Will be.
Yeah, maybe 2.5.
Is it better to cut half of the upper and half of the lower or something?
You are low enough.
Low
Tend
enough.
to go low rather than
Okay.
go high.
Okay. Sir.
If you have see, the greatest problem with the early tracheostomy is the tube falling out and you're not being able to put it again. It will make false tracks. So the things that you can do in that instance is to use these proline sutures. If the tube is not going, use an endotracheal tube, because like we discussed with this bronchoscope, the endotracheal tube has a bevel. It is easier to guide it into this slit-like opening. It's difficult to guide a tracheostomy tube because it's got a blunt end. So you put an endotracheal tube, ventilate, stabilize the patient, and then you can change it. You can use the endotracheal tube as a stent for a few minutes till you stabilize everything, and then you can put the ET tube back. I mean the tracheostomy tube back. So always next to the patient, make sure that there are appropriate sized ET tube. That size and maybe one size smaller that is available next to the patient at all times.
Sir, in case of impacted foreign bodies, those foreign bodies are too big to be removed through the glottis. Whether it is better to go for a bronchotomy or that is tracheostomy or tracheotomy removal.
No. So what happens is, see, ultimately, if you are having a problem, the foreign body is so big that you are not able to retrieve it. Generally, what will happen is it will come and get stuck at the subglottis or the vocal cords. So now you have a situation where you are holding something and sitting and it's not coming out, and your patient is desaturating because there is no ventilation. So in that instance, the safest thing to do is to open the trachea, put a tracheostomy tube, ventilate the patient. That thing is not going to go past the tracheostomy. The tracheostomy tube will be there and hold it up. Stabilize the patient, and then you can find ways and means to take it out. So you can extend the incision or you can do other things to take it out. But always primary thing is to maintain your airway. That foreign body comes second. So if you are stuck, get the airway sorted out, and then you can always, it will not fall. Once you have a tracheostomy there, nothing is going to go down. It's going to remain stuck there. Then you resettle, recoup. If you want, put proper laryngoscopes. Your patient is stable, you are comfortable, your heart rate is not proportional to patients, inversely proportional to patient's heart rate, 40, 30, 20, and you're just going 100, 200, 300. So stabilize, and then it's risk. These are risky businesses.
Yes.
Yeah.
Sir, if you remove a laryngotomy, tracheotomy, then whether it is good to close it with and put a ET tube and keep it in ventilator, or put in a tracheostomy tube?
No, again, it depends on how sick your patient is.
Yeah.
If you remain in the midline and you suture it well, the trachea will heal well. You don't have to worry too much, unless you have made such a big incision that you expect that trachea will become malastic, in which case you can put. But generally speaking, you close it carefully with interrupted sutures. Either PDS is what we would use, or Maxon. Keep the patient ventilated for 24-48 hours, because what you're handling would have caused a lot of edema.
Okay.
So hopefully by then you can then extubate the patient. Generally they are okay.
Okay. Thank you, sir.
Any questions to Dr. Krishna, Dr. Rao, or Dr. Vikram?
So I think, because we have discussed two ways of doing foreign body. You have seen one being done with flexible scope, and you have seen one with rigid scope. And as is usual, most of the pediatric surgeons are doing removal with rigid scopes, and that's how we have been taught. There are some inherent advantages, disadvantages. Maybe we can, I think since you are doing them with flexible scope, are there absolute contraindications to try to remove it with flexible scope? What do you all think?
I don't think so, sir, because unless it is impacted, it is any sharp anything can be removed by a flexible scope, if provided you are confident.
Okay. Any other questions? Any other comments?
Sir, what is the experience regarding in foreign body with bronchotomy, and how will you do good bronchotomy, safe bronchotomies?
I have not personally had to do. but I know of instances where this had to be done. You must understand that these are difficult cases because your patient is hypoxic. You are doing these kind of procedures in a patient simply because there is no other way to ventilate the patient. If this is sitting in the right bronchus and the patient is ventilating comfortably, if you can't reach it, you come out and ask for help. You can go back in. The fact that you have to do a bronchotomy, it is a big thing. You have to turn the patient, you have to do a thoracotomy, you have to find where it is, you have to do so it's not usually a bronchotomy, it will end up in the trachea because you are talking about a midline tracheal mass or tracheal foreign body. If it is sitting in the right main bronchus, the child will not be distressed. You will have time to recoup. So these are extreme cases. These are not simple to do, and you might end up with a live child whose brains are fried. So these are real risks. But yes, if you have to do them, you have to do them. Yeah. But fortunately, we have not had this thing. But I know that there have been instances where people have had to do, and yeah. Yeah, no, you can see.
No, he's saying no, that is the contraindication for flexible impacted foreign body.
No, he said everything including impacted.
Impacted means
Okay,
the
so
example.
impacted foreign body is easier to be removed through flexible.
No. Listen, there is no easier and difficult. It is what you are comfortable with.
No,
Okay.
I'm saying how can we remove an impacted foreign body? Like what difficulty will we face and how will we remove an impacted
I have
foreign body?
I have no experience with flexible foreign body removal. It's a relatively new thing in terms of the people who are doing it.
And
So
by
very
rigid,
few. So I think he will be able to
no, by
answer.
rigid, can we remove impacted foreign
Yes,
body?
by rigid you can remove everything. There's no problem.
Impacted, how
Yes.
do, okay.
You move it, you disimpact it with the forceps and then you hold
Push
it.
it.
Yeah. Basically, it is impacted means, so first, for example, this is your bronchus and there is some foreign body. Okay. So because it is a chronicity, a lot of granulation tissue that has surrounded it. So normally, if you want to, now what we do, we hold and we will pull. If it is so impacted that even with the pulling also, if you're not able to remove it, then you have no other option. Rigid scopes have a bigger, better grips compared to flexible scopes, flexible forceps. So even with the rigid forceps also, you are not able to pull it out. Then you need to know other option. You need to go for bronchotomy. Recently, last year we did one bronchotomy, one board pin. So there it was very little bit distal. Initially, the surgeons tried with the rigid one. It could not disimpact. So in the same setting, we underwent for a thoracotomy. So we guided the surgeon from the above into the scope with the light, the point of light. He can identify palpate the foreign body, and then he can do the bronchotomy and remove it.
I guess this setting would have been a more elective setting. This is a retained old foreign body. Yeah.
Sir, another thing that in impacted foreign bodies, what I am using, I try to principle is that you have to go beyond the foreign body. Anything you instrument and it should be pulled down. If the instrument doesn't go beyond it, it is impacted. You can't remove it. So best way is to use a dormia, nitinol dormia. Put the dormia, it will open up after it passes the foreign body by the side of the foreign body. Then you open it and pull it. Once you pull it, you can now grasp with a forceps and bring it down.
Yeah.
If these boys are going for practice, which bronchoscope will you advise to buy?
Madam, if it's left to me, I would recommend a rigid bronchoscope because there are certain inherent advantages with it. One is you use it in different situations, where for some time you will require a rigid bronchoscope. Foreign body is just one indication. Second thing is lot of your equipment is cross used. The same camera can be used on your cystoscope, the same camera can be used on your bronchoscope, the same camera can be used on various things. Sometimes the telescopes are interchangeable. So there are inherent advantages from that point of view from a cost perspective. If you are running a pulmonology service, then you will have a bronchoscope. But it is, as I said, it requires a whole another set of investments. And as pediatric surgeons, that bronchoscope will be underused. The flexible bronchoscope will be underused in your hands. I'm sure he probably does 10 other bronchoscopies or even 20 other bronchoscopies for one foreign body, or the ratio must be much more. You are probably doing 50 diagnostic bronchoscopies for one foreign body. But this usage is not like that. Every rigid bronchoscope you do, it is probably 1 in 2. If you are not doing airway surgery, it is 100%. So, and it's better to be more conversant with that, because if you invest in flexible bronchoscope and you are using it only for a foreign body, it will be underutilized. So that is the reason why.
Cost effective.
And it is it at least, you know, in our, it is safe to do as far as you have a good team that is helping you. There have been accidents either way. There have been accidents with flexible scope that I have witnessed. There have been accidents with rigid scope that I have witnessed. So whichever technique you use one and be familiar with it is all that I suggest. And naturally we are comfortable with rigid scopes because we use it in so many places.
Just a question. What happens if there is an injury with the instrument?
So it depends on what it is. If it is just mucosal and it's bleeding, generally it stops. You can use the, as I told you, you can use the bronchoscope itself to press against it for some time, and generally it stops. You irrigate copiously, wash it out and clear it out. You know, it generally heals. If you perforate, then it depends on how big your perforation is and how much of air leak you're getting. If it's quite proximal, perforation not big, you put an endotracheal tube, cross it, wait for some time, it will heal. If it's a rent, you can actually see a tear, then you have to go in and surgically operate. Madam, for in a newborn, just for looking at the larynx, perhaps yes, but you cannot instrument through that. It is very small. It's very small.
No, by bronchoscope we can. I am doing also in removing foreign body esophagus. You can go to stomachs in small babies. But that is useful. But otherwise it is not useful. And the scope is around, the telescope is around 3 French. So in a newborn you can go for a diagnostic laparoscopy. That telescopes, and very costly, 3-4 lakhs each telescopes.
No, I think that's one of the reasons why that, no, for us, I think rigid scope makes sense because they are cross usable. You invest in certain things which are common across things that you do. And it's
for cost purpose, you buy rigid and you ask your pediatrician to buy flexible. So you can use both.
no, it is. As I said, I think, you know, buy one set and look after it well. It will last you a lifetime. You know, I think, yeah. Flexible scope is nice. The technology is beautiful. We have them. I use them regularly. But still, for foreign bodies, we will go back to rigid scopes. Yeah.
Now there are cheaper handheld flexible scopes.
Yes,
Yeah,
disposable
ones are available.
Disposable
Yeah.
ones.
So the problem is none of them have good working channels.
So-
It's like Olympus where we have the stack. And stack you have to cross use with the endoscope and everything else. Not worth buying just for the pediatric.
No, see, the thing is that if you are using a bronchoscope that does not have a camera on chip, like a bronchoscope that you have to use this connection, it is not good.
Not good.
It's not good. So if you are using a good, whatever, that X190 whatever system or Olympus, which is what we have, it's wonderful. I mean, the images are fantastic. But we don't do procedures with them. If we have to do a procedure, then we would go back to the rigid scope. There are certain inherent advantages. Like I told you, you're looking for a TEF, for example. You are looking for a recurrent TEF, or you're looking for a TEF in a child you suspect a H fistula. It is useful to have that pus because it will open the fistula, which you cannot do with the flexible scope. So they are complementary. I don't think they will replace one another. In my book, anything you need to do to the secondary bronchus, rigid bronchoscope. Anything you need to go down, flexible bronchoscope. That is how we do. Yeah. So till the larynx, transnasal flexible scope. From larynx to the secondary bronchus division, rigid scope. Anything beyond that, we will put the flexible scope.
Any other questions? Any juniors?
So foreign bronchoscope is
Beginners.
not just foreign body. For us, there are a lot of other things.
Yes.
Okay.
So if there
Thank
is,
you.
okay, thank you, sir. I think I think we have concluded our sessions. Like we have covered everything. If there is no more questions, we can stop here. Thank you everyone for joining. The certificates will be issued like email to you. Those who have registered will be emailed to you. Okay. Thank you. Thank you.
Thank you.
You are one who writes in the IIP clinical.
No.
I-
He's a pediatric pharmacist. He's the head of department.
Pleasure. So you're from Kannada?
Yeah.
Sorry? How much of training?
CMAC कभी यूज नहीं किया हूँ